All right, the next paper in this session is titled Oblique Lateral Lumbar Interbody Fusion, or OLLIF, a comparative study of perioperative and clinical outcomes. It's going to be presented by Dr. Abbasi.
Well, thank you very much. And this is my disclosure. Today I'm going to talk about the oblique lateral lumbar interbody fusion, which is distinct from oblique interbody lateral interbody fusion anterior to psoas, or oblique anterior lumbar interbody fusion. In this procedure, practically the patient is prone. We do not detach the muscle, as most of the minimal invasive are aiming to do. And practically we are relying very significant on imaging and electrophysiology to get to our level of interest. As we surgeons know, in a regular surgery we are detaching the muscle, and those muscles are multisegmental. What we do not advertise is that we do not reattach those muscles, and we are dealing with postoperative spasm and so on. Because of that, many minimal invasive techniques are trying to avoid this damage that we cause on the way of getting there, and OLLIF is one of them that utilize the camine triangle. In this procedure, practically some math is involved in that. I'm not going to talk about the technique today, but practically with biplanar fluoroscopic imaging, we get a safe approach in a 45-degree angle to camine triangle with electrophysiology. And the goal of this procedure is to provide a safe corridor from the skin to the disc base. This is done with a tube that is about 8 mm inside, 10 mm outside, and then a series of smart tools are used to provide the discectomy, preparation of the end plate, packing with a biologic, and as well as placement of a cage. The cage is a conical shape that finds its own place and provides significant distraction. When I was doing lots of TLIF, I was using 7 to 10. Now I'm usually using 12 to 15 mm cages that provide distraction of the disc base and foramen and provide what in the literature is called indirect decompression, but we call it anatomical physiological decompression. Now, the end result, if you look at the CAT scan and X-rays, you do not see any different to a TLIF, with the difference that we have not detached the muscle, we have not devascularized the bone, and I think for that reason we are going to come back to that. We see different results. This is a cohort study. I have used all the TLIF before we started doing OLLIF, and then all the OLLIF after we started the OLLIF. The indication is practically the same like the TLIF, except osteogenic stenosis. We do excluded that, as well as scoliosis and gratulitis. We excluded them and packed them in different studies. Now, this is the fluoro time, and in accordance with all other MIS procedure, fluoro time initially is significantly increased because that's where your eyes are, right? That's what you are using for your guidance. But with the time and learning curve, that was significantly down. Now, but what's important is our blood loss is 1/10 of open surgery. The same surgeon and same procedures, same levels. You see the results. Our usual blood loss is about 20 to 40 cc for one level, 1 cage, 4 screws. As well as a hospital stay in initial study that's published is 1.6, in the follow-up study 2.7, and many of those cases, even for 2 levels, literally walk home 2 to 4 hours after the surgery, after putting 2 cages and 6 screws. Practically 1/3 of the people walk home 4 hours after the surgery. Now, this is, I think, the important slide, because most of the MIS techniques has actually added to the time of the surgery, and we can demonstrate that we have actually reduced the time, and that significantly. In almost at every number of the levels, this time of the surgery is significantly shorter. We'll come back to that. Our usual time for a 1-level OLLIF, 1 cage, and 4 screws is about 35 to 45 minutes at this point. Now, we have more than 600 cases, but we have 300 plus of them in our study that we are going to publish. We can demonstrate significant improvement in the pain skin and all history. And complication, if you do enough of anything, you will have complication. But here we can show that our complication, even considering many of those cases are learning curve, is still lower than the TLIF. And the legitimate question is asked, can we achieve the fusion? As a matter of fact, we can achieve the fusion faster and in higher rate we have hypothesized that the reason why we are achieving this fusion faster and in a shorter period of time and better is because we do not devascularize the bone, and we know vascularization of the bone is through the muscle that in most of the open cases we are detaching. Now, this is, I think, important, that curve that is a learning curve that shows we need, even in experienced hands, you need 20 cases or 40 levels to get proficient in that, but that's not different from the literature. Most of new procedures have the same learning curve. Now, in short, no direct resolution is required, but it's possible with the endoscopic technique. Minimal damage to muscle tissue during the approach, which cut down the blood loss time, the surgery time after the surgery to discharge. We can pack the disc inside and outside with biologic, as well as with some modified technique. We are achieving posterolateral fusion additional to posterolateral instrumentation. We have published since then 5 papers. 3 of them are in modified techniques, for example, for scoliosis, which got just published about 3 weeks ago. If you Google us, you will find them. As well as for the 5S1, OLLIF is not possible in a traditional way. We have modified it, and we call it MIS-DLIF, as well as we have transported the technique to the thoracic region. I'm sure you can Google us and find information. Actually, we are right now about 600 cases, more than 1,200 levels. And this shows that this is efficient and get the job done and give the patient clinical improvement we are looking for. And all of that, on top of all of that, as well, we can show that actually this perioperative saving, instead of doing the surgery 2.5 to 3 hours in 35 minutes and sending the patient home sooner, we can, just in the perioperative time, save $12,000 per case. This is one of our published papers, and if you would extrapolate that to the TLIF performed in the United States, it can potential $2.5 billion annual saving just in perioperative saving. In the long run, with the loss, considering loss of productivity and so on, that number goes significantly higher. Now, these are actual current data. Day in, day out, every week, we do 1-level fusion in 35 to 45 minutes and 2-level fusion in 55 to 65 minutes, and those people go home 2 to 4 hours after the surgery with significant pain reduction. And the hospital stays less. Blood loss is generally between 20 and 40 cc. Not a single blood transfusion was necessary. Significant less risk of infection after almost 550 to 600 cases. Not a single deep infection. Only one screw site got infected that did not spread to other sites because this incisions are separated, and that was self-limiting. So Google us up. There's lots of information. We are happy to get you involved and collaborate with you on this. Thank you very much.
Thank you very much. It's a very interesting and compelling study. It makes me feel like a relatively incompetent surgeon. So the next paper is assessment of damage to the iliopsoas muscle